Oh, this is our backups. I was so paranoid.
Wait till we get the green light.
I have a backup question asker, backup questions for the questions, and a backup question for the question. Too bad. I went too far.
Thanks for coming. We're happy to be here. I have lots of questions already. Good morning. We want to say welcome. Particularly, we want to welcome all the classmates that have turned out. A survey has been distributed for you. We ask that you fill that out for us so that we can get a good feel for perception. And as well as we want to welcome the folks that are on the YouTube and the internet. We are glad that you have the opportunity to take part and hear this presentation. These are some of our first-year medical students that are participating in the medical informatics course that's being offered by the university under the leadership of Lori Fitterling and her staff. This is a part of the medical education where students are given articles to read and subsequently review, research, and then in a collaborative manner work together in coming up with formal presentations. These students are held to a higher standard in terms of what it's going to be like when they get out on their clerkships to present cases to attending physicians and other colleagues. So this is not only depth and training of the topic to be learned, but also a good means and way to verify resources, to get up to speed with what the latest research is, as well as the treatment and the ethical components to this. We want to also let you know that the university is trying to work in a very collaborative manner, and we have welcomed nurse practitioner candidates from the Research School of Nursing. So we say thank you for coming. We thank you for your participation, and we look forward to a long relationship in this manner. The topics that are going to be, or the cases that are going to be discussed, are reflective of what sections that have just been completed in the students' curriculum. So we'll have two cases this morning. They'll be from as little as 7 months old and up to 62 years of age. So having said that, you're in for some enjoyable experience, but I will tell you this a little bit. These students have learned most of this on their own. This is self-taught. Yes, the faculty has been involved to help mentor, to help guide, and to offer suggestions. But the vast majority of this has been learned by the students themselves. So having said that, we say welcome, and we'll go ahead and start, Doc.
Good morning, ladies and gentlemen. My name is student Dr. Charles Hirth, and on behalf of Group 17, I'd like to welcome you to our Grand Rounds presentation this morning. For those of you that don't know, here are the members of Group 17. Indicated in bold are our colleagues from the Research College of Nursing. The parents of a 7-month-old boy bring him to the emergency department with a chief complaint of intermittent colicky pain that they believe stems from his abdomen. Recently, he has developed lethargy. A history of present illness has revealed that our patient is a 7-month-old male who is previously healthy and well-nourished. He was born at term via vaginal delivery, and his neuromotor development is adequate for his age. His vaccinations are also up to date. Through further inquiry, we learned that our patient developed a common cold 4 weeks ago with symptoms of rhinorrhea, a low-grade fever, and sneezing. His symptoms subsided after 3 days of treatment with acetaminophen and hydration. Before arriving to the emergency department today, our patient's parents told us that he was suffering from severe episodic pain, he was inconsolably crying and drawing his legs up towards his abdomen. Recently, he has developed lethargy. Between episodes of pain, his parents tell us he was able to sleep and he was behaving relatively normally. It is also important to note that he has vomited gastric contents 4 times in the last 24 hours. His parents tell us that he has an unremarkable past medical history. He has had no previous surgeries and is not currently taking any medications. He also has no known drug allergies. His parents also inform us that there are no significant medical conditions in his family. Our patient's vital signs indicated tachycardia with a heart rate of 180 beats per minute. His blood pressure, temperature, and respiratory rate were all within normal limits. Upon physical examination, we observed a well-nourished and well-hydrated young boy. During our abdominal examination, we noticed that our patient had rigid abdominal muscles. He was also drawing up his legs towards his abdomen. We observed that his peristalsis was augmented and high-pitched. However, no masses were felt and no rebound tenderness was observed. As we can see here in this image, our patient passed a small amount of bloody stool with mucus. Based on our patient's history and physical exam, we decided to order a CBC and a complete metabolic panel. Our CBC indicated a mild leukocytosis with a left shift. Leukocytosis is defined by an increase in total white blood cell count 2 standard deviations above the mean. A left shift refers to a total number of increase in immature leukocytes, particularly neutrophil band cells. In this example of a peripheral blood smear that we can see here, we have normal red blood cells, but we can also see the presence of the neutrophil band cells, indicating a left shift. The results of our complete metabolic panel were all within normal limits. Our initial imaging studies included a plain abdominal X-ray and 1 abdominal ultrasound. Here's our patient's plain abdominal X-ray. We can see here in the left upper quadrant our patient's stomach. Moving distally, it is important to notice that there are dilated loops of small bowel. In between the dilated loops of small bowel, we can see white discolorations indicative of edema. Lastly, we can see absence of colonic gas in the ascending colon here and absence of colonic gas in the descending colon here. Based on our patient's history, physical exam, labs, and imaging, we decided to explore these 4 differential diagnoses. Our first differential diagnosis is acute gastroenteritis. Acute gastroenteritis is a nonspecific term for various pathological states of the gastrointestinal tract caused either by intestinal infection or enterocyte destruction. We considered acute gastroenteritis as a diagnosis because of our patient's mild leukocytosis. However, we ruled out the differential of acute gastroenteritis because of 2 reasons. First, patients suffering from acute gastroenteritis typically present with watery diarrhea without any blood or mucus. As I mentioned earlier, our patient presented to the emergency department with a small amount of bloody stool that also had mucus in it. Secondly, patients suffering from acute gastroenteritis typically present with a fever, and our patient presented to the emergency department afebrile. For our second differential diagnosis, we considered Meckel's diverticulum. Meckel's diverticulum is defined by the incomplete closure of the vitelline duct, often leading to a remnant of tissue in the distal ileum. The rule of 2s defines the classical features seen in Meckel's diverticulum. Meckel's diverticulum is typically seen in roughly 2% of the population with a male to female ratio of 2 to 1. Meckel's diverticulum is typically found within 2 feet of the ileocecal valve and is typically 2 inches in length. Lastly, Meckel's diverticulum typically contains 2 types of ectopic mucosa, gastric and pancreatic. Patients typically present with Meckel's diverticulum asymptomatically. However, when they are symptomatic, they may present with fresh, profuse rectal bleeding secondary to a hemorrhage, or they may present with intermittent crampy abdominal pain like our patient did. However, we did not suspect the diagnosis of Meckel's diverticulum because patients suffering from Meckel's diverticulum usually present asymptomatically. Furthermore, our plain abdominal X-ray did not support the diagnosis of Meckel's diverticulum. Here we see a surgical image of a Meckel's diverticulum, which is a remnant of tissue coming off the distal ileum, which can be seen here. On the right is a Meckel's scan, which is a diagnostic imaging tool used to diagnose Meckel's diverticulum when clinicians are suspicious of this disease. A Meckel's scan is performed when a patient is injected intravenously with a radioisotope to locate gastric mucosa. When patients are suffering from Meckel's diverticulum, they show normal gastric mucosa in the stomach here and normal gastric mucosa in the bladder here. However, this presence of gastric mucosa in the right lower quadrant is indicative of Meckel's diverticulum. We chose not to perform a Meckel's scan on our patient. For our third differential diagnosis, we considered intestinal volvulus. Intestinal volvulus is a rotational anomaly of the gastrointestinal tract leading to twisting of the bowels. Because of our patient's vomiting, we suspected the diagnosis of intestinal volvulus. However, we ruled out the differential of intestinal volvulus for two reasons. First, patients suffering from intestinal volvulus typically present with hemodynamic instability. Our patient presented to the emergency department and was hemodynamically stable. Secondly, patients suffering from intestinal volvulus typically present with a severe electrolyte imbalance. Our patient, on the other hand, presented to the emergency department and had normal electrolyte levels. On the left is a plain abdominal x-ray from a young child suffering from intestinal volvulus. Important here in this x-ray is we can see the rotational anomaly of the gastrointestinal tract here, and as indicated by the black arrow, we can see an extremely distended sigmoid colon, indicative of intestinal volvulus. On the right is our patient's x-ray, and it is not showing any signs of intestinal volvulus. Here's a surgical image of intestinal volvulus. For orientation's sake, we see here what normal small bowel is supposed to look like. And as we move further distally, we can see that the twisting of the bowel has led to not only inflammation, but discoloration. Our final differential, and ultimately our diagnosis, was intussusception. Intussusception refers to a segment of intestine that telescopes or invaginates into the lumen of another immediately adjacent distal segment. Intussusception is characterized by the sudden onset of severe, colicky, progressive abdominal pain, usually accompanied by inconsolable crying and the drawing up of the legs towards the abdomen. As symptoms progress, patients usually become lethargic and irritable. In up to 70% of cases, the blood contains stool. If the stool contains both blood and mucus, it can take on the appearance of currant jelly. On the left is a cartoon image of intussusception, indicating a layer of intestine invaginating or telescoping into the lumen of another immediately adjacent distal segment here. Here is a surgical image of intussusception showing this segment of intestine telescoping or invaginating into this layer of intestine. Ultrasonography is a method of choice when detecting intussusception. The classic ultrasound image of intussusception is a target sign, often referred to as a bullseye, which represents the layers of the intestine within the intestine. On the left is an abdominal ultrasound taken from a patient suffering from intussusception. Here we can see the classic bullseye or target sign. On the right is our patient's abdominal ultrasound, and we can see clearly here the target sign or bullseye indicative of the diagnosis of intussusception. Plain film radiography is less specific and less sensitive than ultrasonography for the diagnosis of intussusception. However, plain film radiography can also indicate some suggestive findings. As I mentioned earlier, we can see the stomach here in the left upper quadrant and the dilated loops of small bowel moving distally. We can also see the edema, as indicated by the white discolorations, and the absence of colonic gas in the ascending colon and in the descending colon, all indicative of the diagnosis of intussusception. This concludes my portion of the presentation, and it is now my pleasure to introduce student Dr. Paul Goldsmith.
I would now like to discuss intussusception in more detail. We will cover the epidemiology, treatment, emerging research, ethics, and patient education involving our case. I will begin with the epidemiology. Intussusception is a common cause of abdominal emergency in infants less than 5 years old. It is also the most common cause of intestinal obstruction in children less than 5, with the majority of cases presenting before the child is 36 months of age. Intussusception is idiopathic in origin, and no direct cause is yet known. It does, however, seem to develop secondary to diseases that would lead to lymphoid hyperplasia and bowel dysmotility. In our patient, a viral infection was noted 4 weeks prior to the development of the disease. The infection subsided within 4 days with only over-the-counter medications. The only genetic component that has been hinted at is a slight predisposition towards the male population. As mentioned in the first part of our presentation, intussusception is a telescoping of a proximal segment of bowel into the distal segment. This can be seen illustrated again on the right. It often develops secondary to pathological lead points, such as Meckel's diverticulum and appendicitis, a lead point being an intrusion of tissue into the intestinal lumen that may lead to the development of intussusception. The telescoping of the bowel causes a compression of the mesentery and the vascular structures and glands contained within. Lymphatic backflow can lead to a decreased waste removal. Compression of the veins causes venous and can lead to edema and eventually hemorrhage. The high pressure also causes an excess secretion of mucus into the intestinal lumen. The mucus, when combined with the blood from the hemorrhage, is one of the clinical manifestations of the disease known as a red currant jelly stool, and will be discussed in more detail shortly. These problems, if unresolved, can progress to intestinal ischemia, a perforation of the bowel, and peritonitis. And if left untreated, the disease is uniformly fatal within 5 days of its onset. In addition to other known etiologies for the disease, there is currently a clinical trial in Ohio focused on studying the underlying mechanisms of a rotavirus vaccine and its relationship to intussusception. The vaccine is suspected to influence gastrointestinal immunology, anatomical structures, and blood and stool cytokine-mediated inflammatory responses. These abnormalities are noted among many diseases, which may lead to the development of intussusception. The red currant jelly stool mentioned moments ago is one of 3 clinical symptoms known as the clinical triad that often presents with intussusception. Also included in this clinical triad is an intermittent or colicky, crampy abdominal pain, which usually lasts between 10 and 20 minutes, and a palpable sausage-shaped mass on the right side of the abdomen. These present in about 2 out of 10 cases of intussusception. Other manifestations include a drawing of the legs towards the abdomen and emesis, which presents in about 10% of patients, although it is usually non-bilious. Our patient presented with all of these, with the exception of the palpable sausage-shaped mass on the abdomen. There are several treatment options that are available for intussusception of both a surgical and non-surgical variety. Non-surgical reduction techniques increase luminal pressure to force the bowel to separate. Non-surgical is also preferred when possible, as it reduces the risks of additional complications. There are several types of non-surgical treatments that may be used, including saline and barium hydrostatic methods and pneumatic air enemas. Barium contrast in specific is useful as both a diagnostic and a therapeutic tool, as the barium provides a medium for radiological imaging during the reduction of the bowel. However, barium contrast is not always indicated, as it can lead to additional complications, such as if there's a perforation and it can lead to an infection. It is also less effective at reducing the bowel than an air enema. A barium enema is seen illustrated on the right, being used for the reduction of intussusception. For these reasons, an air enema is a non-surgical treatment of choice. Surgical techniques are indicated when non-surgical treatments are not successful. If the patient presents with a perforation of the bowel, or if there have been multiple recurrences of intussusception. Our patient was treated unsuccessfully with an air enema twice, and then successfully with surgical intervention without any additional complications. Following a surgical intervention, we can assess both the parasympathetic and the sympathetic nervous system in hopes of rehabilitating our patient and to promote their long-term well-being. The goal of treatment is to balance the parasympathetic and the sympathetic tone. The sympathetic tone can be assessed at the superior mesenteric, the inferior mesenteric, and the celiac ganglion, as well as the corresponding thoracic vertebral levels posteriorly. Cervical spine myofascial release can also be used to assess the parasympathetic nervous system by focusing on the vagus nerve, which supplies most of the innervation to the gastrointestinal tract. Among osteopathic manipulation techniques that may be useful in the rehabilitation of patients with intussusception are the lymphatic pump techniques. Including in these is the opening of the thoracic duct, the thoracic pump, rib raising, and a doming of the diaphragm. Doming of the diaphragm can be seen illustrated on the right. Lymphatic-focused treatments are not indicated in all presentations of the disease, particularly when an infection may be present. Because the disease presents in children who cannot give consent, the parents must give consent for the treatment. In addition, it is also the legal obligation of a physician to screen for child abuse. This is especially important when the child has made multiple hospital visits, appears lethargic, or if the parents are acting suspicious. It is also important to use a best interest standard to determine if the long-term welfare of the child is the top priority. The criteria for this standard include asking if the provider has given accurate medical information, if the parents have the capacity to process the information that's given to them, and if the parents have been coerced into making medical decisions for their child. In our case, the parents and provider passed the given criteria as the child was brought promptly to the hospital and the parents accepted the medical advice that was given to them by their healthcare providers. Although treatments with air enema are usually successful, they do have a relatively high rate of recurrence, which can be as much as 15% of the non-surgical successful reduction techniques. Because of this, it is critically important that the parents be informed of the signs and symptoms of intussusception so that the child may be brought promptly to the hospital if intussusception is suspected. As mentioned previously, surgical intervention and exploration are the next steps if there are multiple recurrences. Among other ethical considerations, it is important to inform the parents of the risks and benefits of vaccinations. As mentioned before, viruses and other pathologies that may lead to increased lymphoid adenopathy and bowel dysmotility can increase one's risk of developing intussusception. While vaccination in general reduces one's risk of developing the disease, there is a documented link between intussusception and a rotavirus vaccine, which is typically given in the first 3 months postnatally. The risk of developing the disease after being given the vaccine can be as high as 1 in 20,000, with the highest risk being within the first 7 days. Thus, once again, informing the parents of the signs and symptoms of intussusception so that they can closely monitor the child during this time is critically important in ensuring that the child can receive prompt medical attention should it be suspected. It is also important to note that one's risk of developing intussusception after being given the vaccine is still significantly lower than one's risk of developing gastroenteritis should they not be given the vaccine. I would now like to welcome my colleague, a registered nurse and nurse practitioner student, to discuss some family considerations.
All right, I'm going to go ahead and talk about some of the family considerations. When you have a kid in, you're going to have to make sure that you address all the family's concerns and to kind of set the expectations. With the non-operative part of this procedure, there's radiology imaging. With the x-ray, the child needs to be able to stay still during all that time. It's really helpful to have a caregiver present. It's usually a lot more cooperative if that's the case. It's also helpful to explain to the family that the enemas, that they're actually what they're being used for, and that they may cause a little bit of discomfort for the child, but they're not actually harming them. Also to let them know that the length of the procedure is probably, for the x-rays and everything, is probably about an hour or so. For the operative phase, it's helpful to let them know that the child will be placed under general anesthesia, that they'll put them to sleep. They'll have about 3 to 4 small incisions placed, and they'll attempt for a manual reduction, and if that's unsuccessful, they'll move on to a resection. There is sometimes appendectomy is performed if it is believed to be a potential cause. Some other considerations need to take into place as family finances. Not everybody is going to be able to come and visit or make the trip, depending on how far it is. Their coverage is important as well, because it's most likely going to be performed at a specialty hospital. Children's hospital would be doing this, and sometimes that's not covered. Work is important to consider because not everyone can get the time off away from work. Not everyone can afford that, and you might have to fill out some FMLA forms to be able to allow someone to be able to keep their job instead of having pressure for missing work and possibly being terminated. The proximity matters because if somebody's coming from out of state or out of town, they may need to be staying in an extended stay location, like an extended stay hotel. Also, there's a possibility, I know that Children's puts people up in the Ronald McDonald House when they're coming from out of town. For the recovery phase, non-operative, we need to explain a little bit about the NG tube. It can look a little daunting, but as you can see, kids get used to it after a while, and it really doesn't even bother them. Just let them know that it's for suction to help their bowel rest and to help with the process. With the non-operative part, if we were able to go that way, it's usually a 12 to 24-hour stay, so it's a lot shorter stay, a lot shorter duration for the patient. Really important for hydration with the enemas and with crying and all the other kinds of things that go on with the child. There could be possible for electrolyte imbalance, and with children it fluctuate very quickly compared to adults. With operative, it's going to be a length of a stay for 1 to 7 days. Wound management, we're going to discuss a little bit about how it needs to stay wet, needs to stay dry and intact for 48 hours. After that, you can do a sponge bath around the area. It's usually going to be, since it's a laparoscopic, it's usually going to be sealed with steri strips, and that we can change the outer bandage on that, but leave the steri strips alone. They'll fall off in about a week. We need to let them know some of the signs of infection, redness, foul odor, fever. Then they'll need to report those if anything is happening. Family needs to know that there is bleeding that is normal. A little bit of bleeding is okay. If it's an amount that increases, they need to put pressure on it for about 5 minutes. And if it's a good amount, 5 minutes of pressure, and then onto a regular diet. Whereas non-operative children can usually return within 12 hours to their normal diet. Activity is about the same. Usually non-operative children are able to return to normal activity pretty quickly. It's actually it's a good idea to promote walking as well with a child with a non-operative part of that. The operative, it's just kind of as tolerated. Pain control, with non-operative, it's not going to be too much of a concern. With the operative part, it is going to be a lot larger because there's going to be a lot more pain just because of the incisions and everything, and then also there will be some CO2 buildup that's referred to the shoulder, so that's to be expected as well. That's something the family would definitely need to know. Also let them know with if it was operative that they need to not use aspirin, as it's an anticoagulant. And I'm just going to move it on to question and answer now. Thank you.
All right, I know you guys have got some questions, so we can start over here and we'll move our way in that direction. Introduce yourself.
Hi, I'm Ben Wood. I'm a nurse and nurse practitioner candidate. So one of the questions about the FMLA paperwork, it's a way that people can leave their work and fill out a form. The physicians usually fill it out to validate that somebody's just not trying to get off of work, for some random reason, like not proof that their loved one is in the hospital, basically, and they need to care for them, especially for a young child, and they can keep their job. I think that's pretty much the question.
Hi, my name is Travis Tebow, and I'm a student nurse practitioner at Research College of Nursing as well. My question was, what is defined as colicky pain? So this is something that you'll see referred in healthcare all the time, and until I actually researched it just now, I didn't know the true definition of it. So it is actually abdominal pain that comes and goes. What I didn't know about that is for true colicky pain to occur, it is actually has to occur without pain prior to that. So renal and biliary colic is not actually true colicky pain. And like I said, the baseline of pain prior to that would distinguish it. So with colicky pain, it's a result of obstruction or passage and a viscous, but is usually functional and secondary to IBS. So irritable bowel syndrome, appendicitis, large bowel obstruction, small bowel obstruction, lead poisoning, those are all causes of colicky pain. And in the case of intussusception, that is actually caused from the resultant edema and compression on the blood vessels and the nerves.
Good morning, everyone. I'm student Dr. Nima Gamire, and I'll be answering the following question. Did the common cold have any role in causing his symptoms leading to intussusception? There is an increasing amount of evidence suggesting a viral trigger playing a role in some cases of intussusception. Approximately 30% of patients experience viral illness, upper respiratory infections, ear infections, flu-like symptoms before the onset of intussusception. Furthermore, the incidence of intussusception has a seasonal variation, with peaks coinciding with seasonal viral gastroenteritis. Gastroenteritis viruses such as adenovirus, rotavirus can stimulate the lymphatic tissue in the intestinal tract, resulting in the hypertrophy of Peyer's patches in the terminal ileum, which can then act as a lead point for intussusception.
Hi everyone, I'm student Dr. Derek Ha. So my question was, can intussusception develop in adults and why? So intestinal intussusception can develop in adults, but it's extremely rare, accounting for only 1 to 5% of mechanical bowel obstructions. Usually it's due to a pathologic lead point within the bowel, which is put forward by normal peristalsis, leading to telescoping into another segment of bowel. So an increased incidence of intussusception has also been reported in patients with acquired immune deficiency syndrome, otherwise known as AIDS, which is due to the high incidence of infectious and neoplastic conditions of the bowel.
Good morning, everyone. My name is student Dr. Zain Izhar, and the question posed to us was, what is peritonitis and what would be present on a physical exam? According to Clinical Key and the Mayo Clinic, peritonitis is the inflammation of the peritoneum, which is a silk-like membrane that lines the inner abdominal wall and covers many organs within the abdomen. Peritonitis is typically due to a bacterial or fungal infection and can result from a perforation in the abdomen or due to a complication from an existing medical condition. On physical examination, patients with peritonitis generally appear unwell and in acute distress. Almost all patients demonstrate tenderness to application at the abdomen, and referred rebound tenderness roughly overlies the pathological site of peritoneal irritation, and the abdomen is commonly distended with hypoactive to absent bowel sounds. Patients with severe peritonitis often avoid all motion and present with constant flexion of the hips in order to relieve the abdominal wall tension that may be present. A similar question posed was on the significance of having no rebound tenderness. And as I mentioned, rebound tenderness, also known as Blumberg sign, is a clinical sign that is elicited during physical examination of a patient's abdomen. And it often, it refers to pain upon removal of pressure rather than the application of pressure to the abdomen, and is indicative of peritonitis. The absence of rebound tenderness lowers the likelihood of a diagnosis such as appendicitis that typically presents with peritonitis.
Good morning. My name is student Dr. Zuyan Huang, and the question I got is there a genetic predisposition for intussusception? So there's a study by Oshia et al. That was published in 2007 in the Journal of Pediatric Surgery that suggests that idiopathic intussusception does have a strong familial tendency. And the authors concluded that hereditary predispositions, such as anatomical basis, may be a cause of many cases of idiopathic intussusception. So some examples of these congenital anatomic predispositions are various degrees of malrotation or a disproportion between the size of the ileum and the ileocolic valve. In these predisposed families, if they have an inducement such as a viral infection, they can get intussusception very easily. So if you have a knowledge of previous history of familial intussusception, it can help in achieving an early visit to the hospital, prompt diagnosis, and treatment.
I'm student Dr. Jared Hyde, and I received the question, how common is intussusception in adults, and what is the most common lead point? So according to a paper published in 2008 in the journal called Clinics in Colon and Rectal Surgery, adult intussusception is not that common, accounting for only 5% of all reported cases of intussusception in adult and pediatric cases, and only 1% to 5% of all cases of adult bowel obstruction. The mean age for intussusception in adults is 50 years of age, and the incidence is about the same in men and women. Most adult intussusception cases arise from the small intestine rather than the colon. And in contrast to pediatric intussusception, 90% of adult cases will have a lead point, while the remaining 10% are idiopathic. Benign or malignant neoplasms cause roughly 2/3 of intussusception cases when a specific lead point is identified, while the remaining cases are caused by infections, postoperative adhesions, Crohn's granulomas, intestinal ulcers, and congenital abnormalities such as Meckel's diverticulum. The most common malignant neoplasm is a primary adenocarcinoma, and the most common benign growth is a lipoma.
Good morning, my name is student Dr. Jackie Groshek, and I received the question, how does a Meckel's diverticulum become symptomatic and how is it treated? So many times the diagnosis of a Meckel's diverticulum is difficult because patients are asymptomatic and commonly the anomaly is actually found incidentally. However, if you recall the rule of twos that Charlie talked about with Meckel's diverticulum, one component of the rule is that there are two types of ectopic tissue in a diverticulum, gastric and pancreatic. So because of the ectopic gastric tissue, hydrochloric acid is being actively secreted, which may create a chronic ulcer and can damage the adjacent ileal mucosa. The patient might have profuse rectal bleeding secondary to hemorrhage of the ulcer. Another complication could be inflammation and infection of the diverticulum, which is then referred to as a diverticulitis. And this could be caused from stasis or poor circulation to the diverticulum. And the inflamed diverticulum could ultimately lead to an intestinal obstruction with the patient presenting with abdominal pain, periumbilical tenderness, and vomiting. So if the patient has any of these symptoms with Meckel's diverticulum, then a surgical resection is indicated.
Good morning. Another question we received was, what is Dan sign? Dan sign is the hallmark physical finding in intussusception. It's a right hypochondrium sausage-shaped mass, and also there's emptiness in the right lower quadrant, which is caused from movement of the cecum out of normal position.
Good morning. My name is student Dr. Garrett Gaffney. The question I'll be addressing is concerning the stepladder sign, which can be observed with an erect abdominal radiograph when dealing with small bowel obstructions. This produces gaseous distension of the bowel loops proximal to the obstruction. If this obstruction is somewhat distal in the small intestines, they appear to be stacked on top of each other in a characteristic stepladder configuration. This happens as more loops of small bowel become distended with air.
Okay, thank you very much. We are blessed to have one of our associates who is a pediatrician, boarded in pediatrics as well as emergency medicine. So I've invited Dr. Granito to make some comments relevant to this particular case and his experience that he's seen in the emergency room and subsequently in clinical practice. Dr. Granito.
Thank you, Dr. Johnson, and congratulations to all of you for doing a very nice job with your presentation. And this sort of exercise, this sort of presenting skills that you did today, you will do again routinely over and over again in third and fourth year. So good practice for that, and good job. You know, intussusception is actually a fairly common diagnosis that you'll consider in children who present almost classically exactly the way this young boy did. One of the challenges in any setting where you're seeing acute children with acute pain is who to work up and who to image. Some will just be diagnosed based on history and physical, and those who appear to you to be sicker will require more advanced techniques such as imaging. one of the hallmarks, sorry, one of the trends that we now see is that ultrasound is almost completely supplanting plain x-ray. So likely this sort of child's presentation would not result in an x-ray. This is a classic presentation, and having the x-ray discussion in the article is a great educational value. In reality, we would probably skip the x-ray step and go directly to ultrasound if this child presented this way, as the x-ray would be a nice picture to see those loops of small bowel, but wouldn't be diagnostic because you're still going to go on the next step to do the ultrasound. I'm going to make a minor comment about the discussion about general anesthesia, and we'll use words like this all the time, and I want you to be careful when you're seeing pediatric patients who are going to go for general anesthesia and you're explaining that to parents. We commonly use the words, put them to sleep. And to a child, the only time they have ever heard those words before is when? When they put their dog down for euthanasia. So not a subtle thing. Be careful to not use those words when you're discussing general anesthesia in front of a child. It's a very scary thing for you to have just said to them, we're going to put your child to sleep. They're going to freak out. So be careful with those words. Things like, we're going to give medication to make you drowsy, we're going to give medication to make you more relaxed, we're going to give you medication so you can avoid the pain, are way more appropriate words to use. So just a little bit of cautionary note on that.
Thank you, sir. From a critique perspective, I thought your presentation was excellent. Your content is very good. Your depth of knowledge for your slides, the way that you guys answered these questions, I thought it was very strong, very complete, and you researched that through the medical informatics depth of knowledge that you've acquired. Overall, I think you did a great job, and let's give them a good hand, and the next group, come on up.
Just click it. Got it. Thank you.
I'm not speaking, but yes.
That's fine. You want to say well.
Thank you, I appreciate it.
Nobody knows more about this case than you guys. So be yourself, relax, and go through this as a teaching exercise to your colleagues. Okay?
Sure.
It's going to be fine.
Thank you. So for questions and stuff, I emailed you guys saying if you guys should be anticipating questions, and then had a document put together that you should ask you guys to put like have questions.
All right, guys, we'll go ahead and start the second presentation. Go ahead.
Good morning. Testing. Yep. Good morning, students, faculty, and members of the community. Thank you for joining us today for our Grand Rounds presentation. I am student Dr. Arya Kamarahi, and my group and I are here today to present a case about a 64-year-old woman with recurrent gastrointestinal bleeding. These are the student doctors and nurse practitioner students of our group. I will start off our case by discussing the patient's clinical presentation, our differential diagnosis, and final diagnosis. Our patient was directly transferred from our primary care physician's office to the emergency department with the chief complaint of episodes of painless rectal bleeding for an unknown duration. Our patient, a 64-year-old female, upon examination, stated that she could hardly walk. She experiences dyspnea on exertion, chest pain, and tinnitus. Patient denies any history of gastrointestinal ulcers, liver disease, or bleeding disorder. The patient also denies the use of anticoagulants, aspirin, and non-steroidal anti-inflammatory drugs. These are important considerations to take into account, as NSAIDs increase the risk for gastric ulcers, and anticoagulants can thin the blood and increase the risk for bleeding. Therefore, it is important to note that our patient has not taken these medications. Here, we have illustrated our patient's past medical history. It is important to highlight her previous cases of chronic anemia, chronic diverticulosis, recurrent rectal bleeding, chronic palps, and coronary artery disease, as these previous conditions present with similar symptoms that she is currently experiencing. As a result of her similar symptoms in the past, our patient has been tested extensively. She has been hospitalized twice, received multiple blood transfusions. However, the colonoscopies and endoscopies have not been revealing. Our patient denies smoking, consuming alcohol, or using recreational drugs. Assessment of our patient's vital signs indicated that our patient is tachycardic, which means she has a heart rate greater than 100 beats per minute, and she is tachypneic, which is in agreement with the dyspnea our patient has been experiencing upon exertion. In addition, our patient has a mildly elevated systolic blood pressure, and she presented with orthostatic hypotension. Upon physical examination, it was evident that our patient was pale, cachectic, and had dry oral mucosa. Head and neck examinations revealed no abnormalities. Heart examinations demonstrated tachycardia, a mild systolic murmur of unspecified location, and normal S1 and S2 sounds. Peripheral pulses of the upper and lower extremity were faintly palpable, and they were graded as 1 out of 4. A venous shunt was palpated in the right upper extremity with normal thrill. The venous shunt is due to the hemodialysis the patient receives for end-stage renal disease. Lung examinations were clear to auscultation bilaterally with the evidence of tachypnea. Abdominal examinations revealed that our patient was obese, perturbant, and the patient was soft on light palpation. Upon deep palpation, the patient was non-tender, did not experience any rebound tenderness or guarding. Normal bowel sounds were auscultated in all 4 quadrants. Rectal examinations demonstrated dark red blood in the rectum, and external hemorrhoids were detected without visible active bleeding. The rest of the examination was unremarkable. Given our patient's presentation of dyspnea on exertion and chest pain, in addition to her vast number of comorbidities, there was suspicion of a simultaneous cardiac event. As such, a chest radiograph was ordered. However, no abnormalities were detected. Furthermore, given our patient's past medical history of coronary artery disease and her current presentation of a mild systolic murmur with faint peripheral pulse, cardiac enzymes and an ECG were ordered. Tests indicated that cardiac enzymes were normal, while an ECG demonstrated sinus tachycardia. Therefore, a myocardial infarction was ruled out. Liver enzymes per exam were normal as well. Further laboratory examinations indicated that our patient had significantly low hemoglobin and hematocrit levels. as indicated here in comparison to the reference values. Hemoglobin levels less than 6.5 grams per deciliter are graded as 4.4 and characterized as severe. Therefore, our patient with a hemoglobin of only 3.6 is severely anemic, and as such, the patient received immediate intervention. Our patient was given intravenous fluids packed with red blood cells to increase her total blood volume and a proton pump inhibitor to decrease the risk of further erosion of the GI mucosa by acid secretion due to our suspicion of GI bleed. Following treatment for anemia, a gastroenterologist was urgently consulted. Since the patient's cardiac enzymes came back normal and her hemoglobin level was severely low, a significant bleed was suspected in the GI, prompting the GI consult. GI conducted a esophagogastroduodenoscopy, EGD, and the indications for this test in our patient include hematemesis and unexplained anemia. However, the results for this procedure were inconclusive as no active source of bleeding could be detected. We will further elaborate on this procedure later on in our presentation. In addition, an autologous red blood cell scan was conducted, which is highly sensitive to identifying sites of active bleeding. The results for this test were unremarkable. Given that we suspected obscure GI bleeding, the next test that was ordered was an anterograde single balloon enteroscopy with fluoroscopy. In a study conducted in 2012, an anterograde enteroscopy was found to be more effective in terms of diagnostic capabilities than a retrograde enteroscopy for the evaluation of the small bowel. As shown here in the picture, this procedure indicated an active bleeding of 160 centimeters from the incisors in our patient, which is approximately the mid-jejunum. After the area was flushed with tap water, the vessels were visualized with normal surrounding mucosa without any evidence of ulcerations. Our patient's clinical presentation leads us to explore the following differential diagnoses, with the first being esophageal varices. Esophageal varices refers to dilated collateral veins in the esophagus, which can occur in cases of portal hypertension. As shown in the figure, given the anastomosis shared between the portal vein and the submucosal veins of the inferior esophagus, a blockage or hypertension within the hepatic portal vein can cause a reversal of blood flow to the esophageal vasculature. This large volume of blood flow to the submucosal veins can dilate the esophageal veins and result in esophageal varices, which are prone to rupture and hemorrhage. This condition was explored as our patient had presented with anemia and lab results had indicated lower than normal levels of hemoglobin and hematocrit. However, our patient did not present the signs and symptoms of hematemesis, lightheadedness and loss of consciousness, or melena, which is associated with upper GI bleeding, thus making this diagnosis unlikely. Also, it is important to note that our patient denies consuming any alcohol, which is known to be a key risk factor for developing portal hypertension, which can contribute to esophageal varices. Finally, an upper endoscopy did not reveal dilated veins with red streaks and red spots. The picture on the right here demonstrates how the esophageal varices would have appeared if our patient had them. They are ropey, purple, tortuous vessels within the esophagus. As a result, this diagnosis was ruled out. The next condition we explored was diverticular bleeding. Diverticular bleeding is one of the most common causes of lower GI bleeding. Diverticulosis is a sac-like protrusion of the colon wall. The picture on the left demonstrates how diverticulosis would appear from outside of the colon, while the picture on the right demonstrates how the condition would appear from inside of the colon. Over time, as injury occurs on the vessel wall along its luminal aspect, the protrusions predisposes the blood vessels to rupture, resulting in diverticular bleeding. Given that our patient had a previous case of chronic diverticulosis, diverticular bleeding was considered as a diagnosis as our patient exhibited the following symptoms and risk factors as highlighted. The loss of blood as a result of diverticular bleeding would have also accounted for our patient's tachycardia, faint peripheral pulse, and the patient's pale appearance, thus making this diagnosis plausible. However, Based on the workup that was done, the bleeding was indicated to be occurring within the small bowel, whereas diverticular bleeding is much more common within the colon. As such, this condition was ruled out. The next diagnosis we explored was Dieulafoy lesions. This lesion refers to a dilated, aberrant submucosal artery that erodes the overlying GI mucosa in the absence of any ulcers or aneurysm. This potential diagnosis was considered given that our patient exhibited many of the signs and symptoms for this condition as highlighted. In addition, an anterograde endoscopy indicated an upper GI bleeding that was found in a clearly visible vessel with normal surrounding mucosa without any evidence of ulcerations. It is important to note that this condition is difficult to diagnose, which is why our initial endoscopy was false negative for upper GI bleeding. Dieulafoy lesions are small, they have an intermittent pattern of bleeding, and they are self-limiting. Therefore, this condition can only be diagnosed with confidence, either just after or during the occurrence of active bleeding. Given the symptoms presented by our patient and the findings of the anterograde single balloon endoscopy, our diagnosis for our patient is Dieulafoy lesions of the small bowel. Next, I would like to introduce student Dr. Jana Klein to discuss the disease pathology and associated considerations.
Thank you, student Dr. Kamarahi. My name is student Dr. Jana Klein, and I will be presenting the disease pathology behind Dieulafoy lesion, the treatment, emerging research, ethics, and patient education. The Dieulafoy lesion is a large, tortuous, caliber-persistent artery that resides in the submucosal layer that is about 1 to 3 millimeters in diameter and can expand up to 10 times the diameter of normal mucosal capillaries, which is unlike normal vessels in the gastrointestinal tract, which become progressively smaller in the periphery. The aberrant artery can protrude through a small mucosal defect and can become susceptible to even minor mucosal defects, such as mechanical trauma, for example, passage of a food bolus, colon, or stool passing through the colon, where the artery can eventually erode into the lumen, causing an acute GI bleed. This lesion can occur in numerous regions within the GI tract, but most commonly occurs in the lesser curvature of the stomach. And about 80 to 95% of these cases are within 6 centimeters of the gastroesophageal junction. This tendency has raised speculation as to whether or not Dieulafoy lesion is a congenital issue as a result of abnormal embryological folding. Here on the left is a histological sample of the mucosal layers of the stomach. The lumen is shown here to help you with orientation, and this section nicely displays a gastric pit. In the mucosal layer, it's comprised of the lamina propria, which has the gastric glands, and is underlined by muscularis mucosa. Just beneath the mucosal layer is the submucosa, which is where the blood vessels reside. The submucosa overlies the muscularis externa, which in the stomach has 3 different layers of muscle. As you can see, in Dieulafoy, the blood vessels in the submucosa would undergo significant expansion, therefore hindering its neighboring structures transmurally. On the right is a gross anatomical representation of the GI tract, and the gastroesophageal region would be right here, where the Dieulafoy lesion typically resides within 6 centimeters from that site, and most commonly in the lesser curvature of the stomach. In the case of our patient, it was in the mid-jejunum. Please note that these lesions can occur anywhere along the gastrointestinal tract. About 6% of patients present with non-varicose bleeding in the upper GI tract. However, like in the case of our patient, 1 to 2% of all forms present with upper GI hemorrhages. It is typically seen twice as common in males than in females, and risk significantly rises within the 5th decade of life. These hemorrhages are often associated in patients who present with numerous comorbidities with an absence of NSAID and alcohol use. There are two possible hypotheses to support Dieulafoy lesion pathology. The first of which speculates that pulsation in the large artery slowly erodes the epithelium and ruptures the vessel. However, the intermittent nature of these lesions disagrees with the idea that a constant pulse causes the hemorrhage. The second hypothesis suggests that vascular malformation is the cause of Dieulafoy lesions, where thrombosis within the artery leads to necrosis of the arterial walls. There are several diagnostic options that have been investigated in Dieulafoy lesion, the most successful of which has been esophagogastroduodenoscopy, also known as EGD or upper endoscopy. As you can see here, EGD is a relatively quick, non-surgical procedure in which a long, flexible tube with a camera is passed through the patient's mouth to visualize the inner lining of the upper GI tract. This procedure allows instruments to be inserted through the scope, making it a therapeutic tool as well as a diagnostic one. Angiography could also be used, where contrast extravasation into the artery could help in localizing the lesion. Even more sensitive is a red cell scan, which is performed by using technetium-99 labeled erythrocytes to detect bleeding after non-diagnostic endoscopies. On the right is an example of one of these red cell scans, also known as scintigraphy, which can be used for very slow GI bleeds, or for bleeding from obscure sites, as shown here by the arrow. It can localize bleeding at a site of a rate of 0.1 milliliters per minute. Therapeutic endoscopy is the preferred procedural modality for the diagnosis and treatment of the upper gastrointestinal hemorrhages because of the low complication rate and high accuracy. This can be done using thermal, heat, or argon plasma coagulation, where scope probe is used to heat the mucosa, leading to edema, coagulation of tissue proteins, and contraction of the arteries. Heat may be produced by tissue absorption of laser light energy, passage of electrical current, or heat diffusion through another source. In the picture, an ND-YAG laser is shown and used. Supplemented with endoscopy treatment, aliquoted injections of epinephrine or sclerotherapy could also be used to further achieve hemostasis. This epinephrine produces vasoconstriction and activates platelet coagulation, potentiating thermal therapy and reducing blood flow. The most commonly used treatment for Dieulafoy lesion is hemoclipping. Hemoclips can open and close while being operated through a working channel of the endoscope, which will be shown here in the following video. The scope is inserted into the lumen here, where the bleed is visualized. These hemoclips may be used to pinch off or clip a bleeding vessel, which, when fully deployed, they remain fastened to the vessel after the endoscope has been removed from the patient. Our patient underwent therapeutic endoscopy with 3 hemoclips without any complications and was discharged shortly thereafter. At her 2-month follow-up, her hemoglobin levels had risen to normal at 10 grams per deciliter, and she no longer displayed hemorrhagic diathesis, which is indicative of a successful hemostasis. If therapeutic endoscopy does not work and is ineffective, which is generally considered to be the gold standard, angiography with gel foam embolization would be used. An embolizing agent is inserted through a catheter inside the artery to prevent blood flow. Different types of embolic agents could include heat, beads, coils, and gel foam. However, if collateral vessels are present, this method will not work, leading us to surgery as a final option, which induces significant risk factors. There are studies being done using various diagnostic modalities to detect Dieulafoy lesion, such as computed tomography. On the figure to the right is an axial image of a CT angiography of the abdomen in a patient with a known Dieulafoy lesion. The yellow arrow indicates an enlarged submucosal arteriole in the gastric fundus. More research is being done to improve prognostic outcomes using various hemostatic techniques, such as hemostatic sprays and powders, over-the-scope clips, and endoscopic ultrasound-guided cyanoacrylic glue injections. Due to the uncertainty of how osteopathic manipulation will affect the body in patients of the GI bleeds, as a result of the lack of research, OMM is deemed contraindicated at this time. As far as ethical considerations are concerned, obtaining patient consent by keeping the patient or their durable power of attorney informed is critical to understand the risks and benefits behind their treatment. It should also be recognized that Jehovah's Witness patients often forego transfusions due to their religious practices, and their spiritual beliefs should be taken into account by the providers. Our patient also presented with numerous comorbidities, aside from the acute GI bleed, and therefore proper management of her health and discussion about regular follow-ups with her PCP should be addressed as well. Once released, the patient should be scheduled for a follow-up with her primary care physician within 1 week, considering there is risk of rebleeding from the Dieulafoy lesion. That is reported to be between 9 and 40%. The risk is greater in endoscopic monotherapies as compared with combined endoscopic therapies. Repeat lab testing would be performed at this time, specifically looking at a complete blood count, a complete metabolic panel, occult blood testing, hemoglobin, and hematocrit lab values. A thorough physical exam should be performed, focusing on the following symptomology: abdominal pain, chest pain, change in stool, fatigue, pallor, capillary refill, reported dyspnea, and hemodynamic stability. The American Gastroenterological Association advises the following with patients in upper GI bleeds: follow up every 2 weeks to ensure proper site healing and monitoring, consider alternative therapies to NSAIDs, consider proton pump inhibitor therapy, seek immediate help if rebleeding is noted, seeing as acute onset of GI bleeding after diagnosis and interventional treatment of Dieulafoy requires emergent care, sustain a diet with fruits, vegetables, and leafy greens as a source of iron, calcium, and vitamin A, and lastly, a referral to gastroenterology as needed for long-term follow-up. We would like to thank our professors for helping us with our Grand Rounds presentation, and we would now like to open the floor for any questions. Thank you.
Well done. We'll go ahead and start here, and then we'll move in that direction.
Good morning. Student Dr. Bilal Khan. The question that I received was, what is argon plasma coagulation, and how can it be used in Dieulafoy lesion management? So, argon plasma coagulation, according to UpToDate, is a non-contact method of thermal hemostasis that has been successfully used for conditions with GI bleeds such as Dieulafoy lesion, angiodysplasia, and ulcers. And it's a fairly new method that has been developed in the last 20 years or so. It is considered an alternative to thermal coagulation and other non-contact methods such as laser. The advantages are that it's cheaper than laser and it is safer than traditional thermal coagulation due to reduced depth needed for the probe. So overall, in the procedure, utilize a probe that is inserted via an endoscope to deliver argon gas. The argon gas is ionized via a high voltage spark at the end of the probe, and this allows the argon to settle in and distribute thermal energy to the tissue. So overall, the purpose of this is to provide hemostasis, and this would be needed in a Dieulafoy lesion case in case the submucosal artery has eroded and hemorrhaging is taking place. So also it's particularly important in our patient due to the anemia, and we'd like to control that.
Good morning. My name is student Dr. Chris Kostelnik, and the question that I was asked was, if esophageal varices were to rupture, how would you attenuate the bleeding? And according to UpToDate, you start with, on patient presentation, you start with a pharmacological agent such as terlipressin, even before you actually make or confirm the diagnosis of an esophageal bleed or a variceal bleed, followed by endoscopic diagnosis with endoscopic treatment such as balloon tamponade to control the bleeding.
My name is student Dr. Samantha Leong, and the question that I got was, what was the relevance of denying the use of anticoagulants, alcohol, and aspirin in this patient's case? So she already had a history of recurrent bleeding and anemia, so anticoagulants would make that bleeding and blood loss worse. The use of alcohol can cause just erosions of the gastric mucosa, which would have indicated initially more of an ulcerative cause of her recurrent rectal bleeding. And then the use of aspirin would inhibit the cyclooxygenase 1 in the GI mucosa, which could cause ulcers and also promote bleeding from like pre-existing lesions, which she had. She already had recurrent bleeding and a diagnosis of colonic diverticulosis.
Hi, everyone. I'm student Dr. Oshin Lekwani, and I'll be answering the question, why was this patient administered proton pump inhibitors before a diagnosis was made? So proton pump inhibitors are drugs that reduce acid secretion from parietal cells of the stomach, and they're commonly used for patients with peptic ulcer diseases, gastroesophageal reflux disease, Zollinger-Ellison syndrome, or any other diseases that might cause upper GI bleeding. So in the case of our patient, even though it turned out that she didn't have an ulcer or a reflux disease, it was still a good choice to give her these drugs because the patient did have upper GI bleeding, and proton pump inhibitors also work towards increasing clot formation, which helps to either reduce or stop the bleeding. Having said that, our patient turned out to have Dieulafoy lesions, as was mentioned. And as was mentioned previously in the presentation, Dieulafoy lesions are hard to diagnose due to intermittent bleeding and the need for diagnostic tests to be performed just after or at the time of the bleeding episode. So even though they're good drugs to be given to the patient, administering them may have reduced, may have made it harder for the clinicians to diagnose this patient. We also received another question that reads, what was the cause of the chest pain in this patient? And the chest pain was likely caused due to patient's chronic anemia or low hemoglobin level in the blood, which was exacerbated by the acute GI bleeding. Anemia is often linked to heart disease because the heart has to work harder to pump more blood and oxygen throughout the body, and would explain the chest pain.
Hello, my name is student Dr. Andrew Langell. My first question that I received is, what differentiates an upper GI bleed from a lower GI bleed? And the ligament of Treitz is a suspensory ligament on the fourth part of the duodenum at the intersection of the duodenum and jejunum. And in an upper GI bleed, you're more likely to have melena, which is a black tarry stool, since the blood is partially digested. And then in a lower GI bleed, you're more likely to have hematochezia, since the blood is less likely to be digested. And the second question I have is, what happens to the hemoclips after the patient has healed? Per up to date, they are left in the patient just to maintain hemostasis, and with normal cell epithelial turnover in the GI tract, they typically just fall off on their own and pass with the stool.
Hi, I'm nurse practitioner student Sarah Miller. My question is, why wasn't whole blood given instead of packed red blood cells to correct the anemia? With packed red blood cells, it's whole blood, but it's has the plasma filtered out, which is a large concentration of water. So the patient with packed red blood cells would actually be receiving a higher concentration of hematocrit and hemoglobin, which is what we need for this patient.
Hi, I'm student Dr. Kenneth Kim, and the question I received is, if a lesion were to occur somewhere beyond the duodenum, would the length of a standard EGD be able to diagnose the patient? An EGD is only capable of reaching a foot or so past the stomach into the small intestine. The main reason for that is the twisty nature of the stomach and the duodenum. Once the endoscope reaches the second part of the duodenum, the endoscope will curl within the stomach. As the small intestine is not fixed in place, this makes advancement more difficult. Push endoscopy is a technique used to overcome this problem. To avoid looping in the stomach, a more rigid overtube is backloaded onto the instrument prior to examination. This functions to stiffen the endoscope so that the push can transit successfully along its entire length. Another question I received is, what is the difference between an AVM and a Dieulafoy lesion? The main difference between a Dieulafoy lesion and the arteriovenous malformation is the persistence of a large artery in the mucosa that can be 10 times the size of a mucosal capillary. As Ari and Jan explained, this leads to bleeding in the GI. An arteriovenous malformation occurs due to the lack of the dampening effects of capillaries on the blood flow. The AVM progressively grows over time, and the amount of blood flowing through it increases, forcing the heart to work harder to keep up with the extra blood flow. This deprives the surrounding area of nutrients while resulting in tangles with no capillaries. It can be extremely fragile and prone to bleeding just as a Dieulafoy lesion, but it mainly occurs because of the abnormally direct connections between high pressure arteries and low pressure veins.
Hi, my name is student Dr. Jenny Zhang, and the question I will be answering today is what interventions are made for the different varying grades of anemia. So as in the presentation, we have 4 different grades of anemia, 1 through 4, 4 being the most severe, so less than 6.5 milligrams per deciliter of hemoglobin. But the basis of intervention and treatment is not solely on the grading itself, but more on the cause of the patient. There are different types and causes for anemia. For instance, we have sickle cell anemia, we have anemia secondary to chronic kidney failure or due to iron deficiency or acute or chronic blood loss. And with all these factors contributing, it's very important to have a thorough diagnostic evaluation before coming to a treatment conclusion. So for instance, to treat iron deficiency, we may have to change our diet to increase iron intake, and if that's inadequate, we might have to take iron supplements as well. So depending on the individual patient case, some treatment options might include maybe blood transfusions, erythropoietin therapy, which is we give them, administer an erythropoiesis stimulating agent, which increases the red blood cell formation. And then in case of blood loss, it's crucial to locate the source and stop the bleeding, which may require surgery.
Hi, my name is Angela Tanis. I'm a nurse practitioner candidate. And my question was, why does the patient need to be on proton pump inhibitor therapy long term? As was previously discussed, PPIs such as omeprazole or Protonix are given immediately after any procedure. They help decrease the amount of acid secretions in the stomach. They help neutralize the gastric pH. They also help with clot formation and reduce the risk of clot lysis. Long-term wise, as was discussed, the probability of reoccurrence is about 9 to 40%. Those bleeds are typical arterial. So after the patient is discharged from the hospital and coming into, say, one of our primary care practice clinics, we have a need to monitor those patients closely and help prevent that long-term effect of increasing of the bleeding again.
My name is Alicia. I'm a nurse practitioner student. My question was seeking clarification on the follow-up care of a patient after they have been discharged from an inpatient setting. And also, what did we mean by monitoring closely? So just to kind of clarify a couple points, at the end of our presentation, we mentioned how the patient could be referred off to GI for long-term care if needed. But it's probably circumstantial to providers. One might choose to have GI follow this patient closely as opposed to a primary care provider immediately after discharge, if that is available. Obviously, rural areas, they're not quite so readily available to GI, so primary care, they have the capabilities to monitor this patient as well. Getting the patient in within a week after discharge just to monitor how things are going would be the best circumstance. And then about every 2 weeks until the patient has kind of shown that they have recovered almost fully from the procedure. Once they have indicated that they've recovered nicely from having all of these procedures done, they could kind of widen the gaps between follow-up visits. If they're being followed by a primary care provider and at any point they have any circumstance of going the wrong direction, obviously if it seems emergent, they need to go back to the emergency room. But if it seems more, something that's going to be a chronic issue, then you could refer at that point to be monitored by GI.
Very well done. I want to kind of pick up a little bit on some of those questions that were answered, one of them relevant to the chest pain. And basically, with this lady coming in with a hemoglobin of 3 and having known history of cardiac disease, you well know that a low oxygen carrying capacity is present. So you're right. She didn't have a myocardial infarction, but what she did have was likely an anginal event secondary to low oxygen carrying capacity from the hemoglobin and hematocrit. So you were right. The other component is you've decided to put this patient in the hospital with these type of numbers and this history. What part of the hospital would you put the patient in? Would you put the patient down on the 5th floor at the end of the room, end of the hallway? Probably not. You don't know where these GI bleeds are going to wind up. So you want them in the area of the hospital where the nurses can give the closest attention to that patient, monitoring their vital signs. The other component is on the transfusion side of it, and I wanted to ask Dr. Hubbard, hematologist, oncologist, about the relevance of transfusion. The question was, should we give whole blood versus packed cells in this type of clinical setting? Dr. Hubbard.
Thanks, Dr. J. Great job, everybody. Wonderful presentation. With respect to packed red blood cells versus whole blood, we got away from giving whole blood actually shortly after the Vietnam era when we had trouble with multiply transfused patients having problems. What happened at that time was that they began to develop antibody reactions to the serum. They also developed antibody reactions to white blood cells and platelets. To this day, when you're transfusing patients with packed red blood cells, certain patients will have a fever. It usually is attributable to the white blood cells that are present in that transfusion. So consequently, filters have been utilized. The blood from the community blood center is pre-filtered. But the primary reason why we don't give whole blood anymore and why it's componentized, if that's a word, the reason why we do those sorts of things is to minimize the risk of infusion reactions that can occur during and shortly after the delivery. Whole blood is still a reasonable option in very, very rare circumstances, and we do on occasion utilize it in neurosurgical procedures. Sometimes we'll borrow a little bit of whole blood to make a blood patch or something along those lines. And so we'll still use it, but it's very, very reserved and it's not commonly done anymore.
Thank you, Dr. Hubbard. Upon completion of this presentation, one of your colleagues has an announcement to make, so I'd ask that you remain for just 30 seconds after you've given these folks an excellent round of applause. Thank you.